Good morning, everyone. Today's class is on screening of cervical cancer. Can you hear me?
Ma'am.
Good. Okay. So today's topic is very, very important. I can't stress enough how today's class and my next class, which is on CIN, cervical intraepithelial neoplasia, both of these topics are very important, both from your theory and your practical point of view. Okay. So in today's class, we will first look at what is the burden of cervical cancer in India, and then we're going to define what cervical cancer screening is. We'll look at the rationale or why is it important to do cervical cancer screening. We will do a brief recap of the histology of your cervix to have a more deeper understanding of how cervical cancer screening works. We'll look at the types of screening modalities, the techniques, and your screening schedule. Right? So when we look at CA cervix, it's the second most common malignancy amongst Indian women. Right? So when you look at Indian women, a few years back, CA breast was the most common cancer, at least in urban areas, and CA cervix was the most common cancer in rural setting. But all these, they keep changing over the years. So right now, currently the status is CA cervix is the second most common malignancy amongst Indian women. Okay? And the latest statistics that we have is as per the ICMR of 2018, and the incidence is 22.86%. CA breast is about 27 to 28%. Right? So the second most common malignancy in Indian females is your CA cervix, which is why I understand why this topic is so important. Right? And then the mortality because of cervical cancer is at 67,000, approximately 67,000 per year. Okay, so it's like the number one gynecological cause of mortality in India. Studies have shown, statistics have shown that rural women are at a higher risk of developing cervical cancer as compared to their urban counterparts. Okay, so when we look at the statistics again, 23% incidence in India is 23%, and this accounts for 1/4 of cervical cases and deaths worldwide. Now, what you should understand is that there are many predisposing factors for CA cervix. I believe it's already been covered maybe in your other classes. But if you look at India, okay, the onset of sexual intercourse is much later as compared to the Western world. In the West, we have girls as young as 13 or 14 years who begin their who become active sexually. However, the incidence of cancer is much lesser, even though history of multiple sexual partners and promiscuity is high in the Western world. Their incidence of cervical cancer is very less. One is because of their hygiene. Secondly, because they have such good screening techniques, and most of these girls, it's their routine vaccination to get your HPV vaccination, right? So these are some of the factors why in India we have a higher incidence of cancer as compared to the West. Mortality, as I mentioned before, 67,477. This is the latest statistics as per your ICMR 2018. When you write your exams, just before you write your exams, please look up at these figures again. There may be a change. Okay, so these figures obviously will keep changing from year to year. So it's very important for you, especially before you go and write your entrance examinations, you should update yourself. Right? So as you can see, cervical cancer is a heavy burden on the Indian population. So therefore, what is cervical cancer screening? When we talk about screening, basically it's nothing but a tool. So what we are doing is that we are trying to find changes in the cells of the cervix that could lead to cancer. So when you say that you're screening for cervical cancer, meaning you're trying to look for these early changes that if they were left unattended, untreated, this could further progress to cervical cancer, right? So you're trying to find the early changes in the cells of the cervix. So then what is the rationale? Why is it that we don't have screening for most other type of cancers, but for CA cervix, it's such an important area. When we talk about CA cervix, screening, it forms a very important part of cervical cancer. Why is it so? Because cervical cancer is considered preventable because of its long pre-invasive state. Now, what do I mean when I say long pre-invasive state? Suppose if a person gets infected with your HPV. HPV is your human papilloma virus. It's known to be the main cause of cervical cancer. Now, if a lady was supposed to be infected with HPV, it takes a long time for the cervical cells, okay, from the period of infection to the time that they actually develop to cancer, there's a long time. So we have a long window. And if we were to detect and screen women and then detect some abnormality in the cells earlier on, what we can do is that we can actually prevent disease progression from pre-invasive state to cancer state. So the main thing, even though it's a heavy burden, the plus thing about say cervix is that it has a very long pre-invasive state, which is why we can arrest the progression of this disease from pre-invasive to cancer state, which is why screening makes sense for such a disease where you have a very long pre-invasive state, right? So what happens is that if a woman gets infected with your HPV, okay, your human papilloma virus, and mind you, there are many subtypes of this HPV gene. The ones we are mostly concerned with is your HPV 16 and 18. So what happens is that, like I said, in the West, HPV vaccination is part of their routine vaccination protocol. So even though girls as young as 12, 13, 14 years become sexually active, the very fact that they've got vaccinated kinds of form like a primary prevention for them. Right. Now, for us in India, this is not really part of the immunization schedule for various reasons. We are considered a low resource or a poorer developing country. That is one of the main factors. So now what happens is that once a person gets infected with your HPV vaccine, it takes a long time from HPV infection to progress to your pre-cancer or your CIN, which we'll talk about in your next class, and thereafter for that CIN to develop to cervical cancer. So our aim of screening here, therefore, is at this point of time. Which is why, again, this is very important because in my latest slides, I'll explain to you why, for us, it's very important to actually detect it here. Okay, so this is where it's very feasible for our Indian scenario. So for us, after a person is supposedly infected with HPV, when we screen her and if we detect any abnormality in the cervix, this is where we can take some active intervention. So a brief recap of your cervical histology. So when we look at cervical, this is a brief recap, very important for you to understand today's class. So basically you have your uterus, your cervix, which is nothing but the gateway or the opening of your uterus, and then you have your vagina, right? And this is your endometrial cavity. Now the cervix is further divided into your endo meaning the inner part, okay, or the portion which is closer to the uterus, and you have your ectocervix. Now the endocervix is lined by your columnar epithelial cells which produce mucus, and then your ectocervix, okay, this has your squamous epithelial, right? So endo has columnar and your ectocervix has squamous epithelial, right? So obviously the junction between the endo and the ectocervix will be called the squamo-columnar junction. So what is the transformation zone then? Okay, we'll come to that a bit later. So what happens is your columnar epithelial, like I said, it is in the your endocervix, upper and middle endocervical canal. It's a single layer of columnar cells arranged in folds, and these are mucin producing. Now your original squamous epithelial is in the ectocervix. This is very important. These cells are basically very well glycogenated. They are plump and pink in appearance unless atrophic. What do I mean by unless atrophic? If a patient were to enter menopause, then obviously the squamous epithelial will no longer appear plump and pink. And this pinkness, okay, is usually because of the underlying blood vessels. This is very important. So squamous metaplasia is basically your replacement of your columnar epithelium by your squamous epithelium, and there are various conditions that stimulate this process. Okay, acidic environment with onset of puberty, and your various estrogen surges causing eversion of your endocervix. So there's something known as your original squamo-columnar junction, and where this is, okay, the position, the anatomical position of your squamous columnar junction is determined as early as 18 to 20 weeks gestation, meaning when, if it's a female fetus, while it's still in utero, that is when this starts to form, right? So now what happens is that then there's something called, so that is your original squamocolumnar junction. Now, why is it that then there's a new squamocolumnar junction? Why? Because of various reasons, because of various factors, this original squamocolumnar junction will then migrate to a newer place, right? And the factors which influence the location of this new squamocolumnar junction, the most important is age. Okay, so here's a schematic representation. In neonates, you can see it's up here. Okay, when a lady enters her reproductive age, then your squamocolumnar junction will migrate down here, right? In multiparous, whether it's nulli or multiparous, as long as a woman is in her reproductive age, this is where you'll find it. Then again, with postmenopausal, it regresses. Okay, so age is one of the most important factors. So then what is the transformation zone? This is very important. So I spoke about what the original squamocolumnar junction is, and I spoke about what the new squamocolumnar junction is. So the area between the original and the new squamocolumnar junction is what is known as your transformation zone. And why does this happen? Because of your squamous metaplasia. So this is a physiological process as opposed to your dysplasia, which is a pathological process, right? Types of transformation zone, just good to know, more important for your MCQ point of view. This is again a schematic representation. You have your original, okay, squamocolumnar junction here. Then you have your active squamocolumnar junction here. And what is the transformation zone? The area between your original and your active. So usually this comes as a short note. Okay, transformation zone is a very favorite question, very favorite short note question. So if you can make diagrams like this, very good, right? So you just remember transformation zone is nothing but the area between your original and your active or new squamocolumnar junction, right? So you have your internal os, you have your columnar epithelium, which is the endocervix, you have your squamous epithelium, which is your ectocervix, and the area between the two squamocolumnar junction, the original and the active or the new squamocolumnar junction, is your transformation zone, right? So if you can make a schematic representation like this in your exams, it'll be very, very good and you'll remember it as well. So columnar epithelium is the one in blue, squamous epithelium or the ectocervix is the one in red, and transformation zone is there in between, right? So why am I so worried? Why am I stressing on transformation zone? Why am I taking you back to histology? This is because, okay, the transformation zone, okay, again the area between your original and your active squamocolumnar junction, this is the site where pre-malignancy and malignancy develop, okay, which is why we are so concerned about the transformation zone. Okay, so when we talk about screening of cervical cancer, studies have shown that screening with whatever form of modality, the most commonly used is of course your pap smear, plus HPV vaccination can reduce the cervical cancer incidence worldwide. Okay, now here I've written 21 to 65 years of age. This is more true for your Western world. In India, we take a different age cutoff. Okay, now the reason the Western world they take a lower age cutoff is why? Because age of onset at first sexual activity is much younger as compared to our Indian counterparts. Okay, so for us it really does not make sense. We are really not a high resource country to be able to afford screening at such a young age. So Indian guidelines say otherwise. Now if suppose you're interested to write your US MLE or any foreign exam, so these are the guidelines you would follow. Okay, so therefore again very important slide, what are the various screening modalities for CA cervix? Okay, there are three main screening modalities. Number one is your HPV testing. Why do we do HPV testing? Because obviously HPV is one of the most common risk factors or the infective agent for your CA cervix. So obviously we would like to test for HPV. Cytology or your pap smear can either be conventional or your liquid base. In NEIGHRIMS, what we use is your liquid-based cytology. So in your exams, your examiner may ask you, okay, so what are the different screening modalities and what do you currently use in your hospital? So in NEIGHRIMS, what we use is your liquid-based pap smear, right? Then the third modality is, of course, your visual inspection by acetic acid, okay? So your three main are these, okay? And then the new screening modalities, this is more important from your MCQ point of view rather than for your undergraduate exams. Later on when you write your MCQ, your entrance exams, so this is what the newer screening modalities would include: your P16, your Ki61, mRNA testing, E6, E7 protein testing, which is currently not being done here. Okay, so the three ones, we'll talk about each of these now. So the pap test or your pap smear, what does it do is that it looks for pre-cancer cell changes in the cervix that might become cervical cancer if they are not treated appropriately. So pap smear, we look for cell changes. In your HPV test, obviously we are looking for the HPV virus. Okay, so both of them basically they're both screening modalities, but in one we look for the cells, in the other one we look for the virus. How do we do pap smear? Again, a very, very important question. See, pap smear can either come as a short note or on your examination, in the afternoon viva, when you have your table viva, usually what they'll do is that they'll put a lot of instruments in front of you. And like I've always said, most examiners are very, very nice. They will actually allow you to pick up your own instruments, okay? And then more often than not, they'll always ask you about the eyes spatula, okay? So it's very important, both from your theory and your practical point of view. Again, so what happens is that we have two types of speculums that we commonly use in our gynae OPD. One is the cuscus and the other one is your sim speculum. So they may ask you, in which all procedures would you like to use a cuscus? So one would be while taking a pap smear, right? So what happens is that first the patient has to be laid down in lithotomy position under good light. This is very important. Why do you think it's important? Because we have to visualize the transformation zone, okay? And then we first inspect and see if there's any discharge, if there's any growth, any ulcer. Then we insert a vaginal speculum, cuscus. Now this is very important. We do not use any lubricant. Commonly in NEIGHRIMS, what we do is that we use your lignocaine jelly. Now in case of a pap smear, because we don't want that jelly to come into your pap smear, so we never ever use a lubricant. This is also something that they commonly ask you in your exams. So then when you insert the speculum, the blades are first kept closed, and then when you fully insert the speculum inside, that is when you open the blades. Right, so this is how it would look like. This is schematic representation. So you've made the patient lie down in lithotomy position. Mind you, that's very important, okay, for good exposure of the cervix. And then what you do is that you place your cuscus, this is a cuscus, and then you insert either your eyes spatula or you insert your cyto brush if you're doing liquid-based cytology. In this picture, in this diagram, we can see the eye spatula. So after that, you take, okay, what you do is that the pap smear is taken from where? Transformation zone. Why do we take it from transformation zone? Because that's the area where CINs and your precancerous lesions are most commonly found. And then you make a smear, right? So this is where it is. This is how it should look like, and this is the area from where you should ideally take your pap smear. So the junction of the pink cervical and red endocervical canal, so this is where you would like to take your pap smear, okay? So, and the reason why we do it from here is because this is the most likely site of your pathological change, otherwise known as your dysplasia. So this is how our eye spatula looks like. Like I said, in your afternoon viva, in your table viva, examiners really like to ask questions on your eye spatula. So this is exactly how it looks like. This is the part, okay? The concave part is from where the part that we insert into the cervix, into the transformation zone, and take the pap smear. Now, so what we do is that we rotate it after you've kept it here inside, the longer bit, okay? So at this side, you'll see it's shaped like this. So the longer part, you insert it inside and you rotate it 360 degrees. You have to be very gentle. Okay, if you use too much force, there'll be bleeding. Again, the blood, the RBCs can obscure the staining process. When they look at it under the microscope, it can actually obscure vision. And of course, you don't use too little force. Otherwise, the problem, therefore, with your eye spatula sampling is that it can actually lead to inadequate sampling. So not too much force, not too little force. Rotate it for 360 degrees. So when you insert your cyto brush is used for what? Liquid-based cytology, and this is what we use in NEIGHRIMS. So your examiners are more likely to ask you about your cyto brush. So you insert it about 2 centimeters until the brush is inside the canal. In case of your cyto brush, you only rotate it at 180 degrees. Otherwise, bleeding can occur. Of course, because of the brittleness of your brush, this can cause bleeding. So we do not rotate it 360 as opposed to your eye spatula. We rotate it just 180 degrees, right? So eye spatula, like I said, the longer bit goes inside, rotated 360 degrees. In case of your cyto brush, you insert it inside and you rotate it just 180 degrees, okay? So after you've taken the sample, after you've taken the pap smear, the next thing is to fix the smear. This is very important. So for conventional cytology, I mean when you take your pap smear with your eye spatula and fix it on the slide, the glass slide must be fixed immediately with an appropriate fixative. Most commonly uses your 95% alcohol. And the slides are then transported to your pathology lab, in this case in a container for processing together with the corresponding cytology request form. So labeling is very, very important. Okay. Now what we do is for liquid-based cytology, again I'll stress this is what we do in NEIGHRIMS currently. After you sample the cervix, after you've taken your pap smear, the tip of the sampling device should be broken off into the transport medium, okay, in the container provided, and then it is sent to the lab for processing. So this is how it looks like. After you've taken the smear, the tip is inserted. It has a fixative. The container comes with a fixative inside, and then you break off the tip of the brush, and this is sent in situ, right? So this I've already spoken about fixation. So, but why is fixation and adequate fixation essential? Because it ensures that the cells are well stained and clearly displayed for microscopic analysis and preserved for immediate and future review. Now remember that even in your exams, they can ask you about the fixation, what type of fixation you use. The fixation that we use are alcohol based, right? And the most common, of course, is your 95% ethanol. The spray fixation, so either you can have liquid fixation where you just insert your slide or your brush into a liquid fixative, or you can have a spray fixative, which we currently don't have here. So then what is the advantage of your liquid-based cytology as compared to your pap smear? So now the advantages are the sample takers, whoever the clinician is who's taking the sample, need not prepare a slide and fix them immediately before the cells become air dried. Okay, so now the hassle with taking a conventional pap smear is that after inserting your eye spatula, you need to have a slide nearby. You need to make a smear, okay, and the smear should be appropriate, it should be thin. All that is done away in case of your LBC. So LBC preparations are uniformly well fixed, obviously, because you keep the entire brush in situ into the fixative. Cells not obscured by exudate or blood, smaller area, thereby easier to screen, fewer inadequate tests and repeats. Like I said, in case your pap smear, sometimes because of inadequate, because the eye spatula has not been inserted adequately inside, what can happen is that you do not have adequate cells on your slide. Right? So these are all the advantages of your LBC or liquid-based cytology as compared to your conventional cytology. But mind you, both of these come under pap smear. So now again, another thing, your HPV testing, usually with your liquid-based cytology, okay, ancillary tests such as HPV testing can be carried out in the same vial. So that is the biggest advantage of your LBC over your cytology. So in your HPV testing, so the three modalities I said are your pap smear, secondly HPV testing, and thirdly your VIA or visual inspection with acetic acid. Now the thing with HPV testing is nothing, you just look for your HPV DNA. Right, so there's amplification of your HPV DNA. I'll not go into details of that. So the other modality of treatment is your visual inspection with acetic acid. So what happens is that you inspect the cervix visually, okay, after applying acetic acid. Now this is especially very important in low resource settings. What do I mean when I say low resource? So if you or anyone was supposed to be posted in a PHC where you don't have a pathologist, you don't have a dedicated cytology lab. So what you do is that you just apply acetic acid on the cervix and we look for changes. So in low resource settings, VIA is very convenient. You really don't need many instruments. All you need is just a speculum. You just need your acetic acid and you just need to apply the acetic acid on the cervix and look for visual changes. So in case of low resource settings on resource poor countries like ours, especially when you talk about peripheral health centers or your CHCs, okay, so this is what can be done. And this is shown, studies have shown that this can be equally sensitive as your cytological screening. When I say cytological screening, what do I mean by that? Your pap smear, either conventional or liquid base, right? So VIA has shown to be equally sensitive. So what exactly is VIA, visual inspection with acetic acid? When acetic acid is applied to normal squamous epithelium, where squamous epithelium seen in the ectocervix, right? Little coagulation occurs in the superficial cell layer as this is sparsely nucleated. Okay, so the normal squamous epithelium appears pink and the columnar epithelium appears red because there's very less nucleus. Now, in case of areas of CIN is nothing but your cervical intraepithelial neoplasia. I'll talk about this in my next class. And invasive cancer, what happens is that there's maximum coagulation that occurs. Why? Because these cells which are abnormal have higher content of nuclear protein. Okay, in view of the large number of undifferentiated cells contained, right? So what happens is that in case of your normal cells, they're sparsely nucleated, so there's no coagulation that occurs. But in case of areas or in case of a cervix which has abnormal changes because of the higher content of nuclear protein. So this is the important thing. Normal cells sparsely nucleated. When you talk about undifferentiated cells, they'll have a higher nuclear protein, and this is what coagulates. So this is very, very important. Basically, it's the nucleus, okay, the number of nucleus, undifferentiated nucleus, which is the deciding factor whether there'll be coagulation or not. More nuclear protein, more coagulation. So what happens is that when that area coagulates, it prevents light from passing through the epithelium, right? As a result, the subepithelial vessel pattern is obliterated and the epithelium appears densely white. So in normal squamous epithelium, the plumpness or the pinkness is because of the underlying blood vessels. Now, when you apply acetic acid in a normal cervix, because of the lack of your nuclear protein or the number of nucleuses being lower, there's no coagulation that happens. So the blood vessels that are present subepithelially, they can shine through. Now, in case of any abnormality because of higher nuclear content, this undergoes coagulation and therefore light cannot pass through the white coagulation and the underlying vessel patterns obliterated and therefore it appears densely white. So abnormal is then densely white, normal is pink or red. Okay, just remember that in VIA, when we talk about visual inspection with acetic acid, okay, if it's red or pink, it's normal. If it's white, it is abnormal. And the rationale behind it also, now you understand. Right? So thus the effect of acetic acid will depend upon the amount of cellular proteins present in the epithelium. Areas of increased nuclear activity and DNA content will exhibit the most dramatic white color change. Right? So visual inspection acetic acid. So now you understand it. The first picture is normal or abnormal. Alvarine, Kharpuria will tell me now. Alvarine, picture number
Normal,
one.
ma'am.
Very good. And what about this one? Abhishek Kumar.
Yes, ma'am.
What is this? Abhishek? Can you see my cursor, where my cursor is? The last picture, is this normal or abnormal?
Abnormal.
Very good, right? So red or pink is normal because the vessels underneath will shine through. Anything that is white like this, so this is what we call as aceto-white. any areas of white here, you can see increase in intensity. In this picture, it's lesser. In here also it's lesser. But in this and this, there's extreme whiteness. Okay, so that means the degree of dysplasia is more, right? So VIA positive means aceto white is present. If it's VIA negative, that means there's no aceto white. It'll become either pink or red. It'll retain its normal color. So now we'll look at the sensitivity and specificity. Pap smear sensitivity is much lesser than your HPV testing. However, when you look at the specificity, Pap smear has a higher, slightly higher specificity as compared to your HPV. Why? Because your HPV testing cannot differentiate between persistent and transient infection. Therefore, it has 3 to 4% lower specificity than your cytology or your Pap smear, right? So this is the reason why your HPV testing has a lower specificity as compared to your Pap smear. What is the difference between sensitivity and specificity? Sensitive meaning it can pick up whether it's right or wrong. Specificity meaning it's very specific for that particular disease, right? So we'll just talk about colposcopy a little bit. So now mind you, when we talk about screening, so if suppose you have a relative who's gone in for a pap smear and the pap smear shows some abnormality, mind you, you cannot make a diagnosis based on only on your pap smear. It's supposed to be just a screening test. Your absolute diagnosis, the gold standards, of course, to take a biopsy from the abnormal area. So see, you cannot do a biopsy for everyone. So first you do a screening test, and if there's any abnormality, then only you do a biopsy, then only you get your final diagnosis. That is very important. They will ask you in exams, what is the difference between your screening and your diagnostic tests? So briefly, I'll talk about colposcopy. It's nothing but systemic evaluation of your lower genital tract. So you have your endoscopy, your colonoscopy. So for us in gynae, when you talk about colposcopy, it's nothing but you put a scope into your lower genital tract. So basically, like I said, in a low resource setting, they'll not even have a colposcope. For all you know, maybe they've never even seen one, but in our setting, we do have a colposcopy. So do we do it for all patients? No. We do it in case of patients who have an abnormal pap smear and you want to evaluate the patient further, or in case of suspicious cervix, or if a patient comes in with an HPV positive report, and in case of VIA positive. Okay, so the principle is that it recognizes abnormal sites, define extent of lesion, and exclude invasive disease. Right, so what you do in colposcope is that this is how it looks like, and then we actually have one in the OPD, right? So it's an outpatient examination, nothing but magnification of your cervix using a light source. It is used both for diagnosis, especially in case of abnormal pap smear or where it's undetermined. And then what happened, it can also use for treatment. How? You can do something known as your colposcopic guided biopsy. Now, in case of colposcopy, the same thing you still use a 5% acetic acid, right? And like I said, if there's more activity, if there's more nucleus, okay, these will coagulate and then that will turn white, okay? So wherever there's increased cell turnover, obviously there'll be more nuclear activity. These areas will coagulate more. So, for example, abnormal area, like suppose your CIN will then appear white as can be seen here. And what we do further with colposcopy is that we then take a biopsy from the area that appears white. Now suppose you've already magnified it. See here the surrounding area is red, here it is white. So you would take a colposcopic guided biopsy only from the area where it's actually white. Now this is also important. Shillong's test is what you do. You apply iodine. This is only for colposcopy, mind you. So after applying your acetic acid, you then apply your iodine. Areas of CIN lack the presence of intracellular glycogen. Now, which type of cells produce glycogen and mucus? You remember? Is it your columnar or your squamous? If you've paid attention, you can answer me now. Okay, never mind. So these cells, okay, that lack intracellular glycogen, they will stain yellow as opposed to normal, which will stain brown when iodine is applied. So very important, in VIA, visual inspection with acetic, normal is red or pink, abnormal is white. In case of iodine, the other thing, the other term you can use is your visual inspection with iodine. In this case, the normal cells, will stain brown when iodine is applied, but the areas of CIN lack the presence of intracellular glycogen. Therefore, they are not able to stain yellow. They cannot take the iodine in, so they will be free of iodine stain as opposed to your normal, which are iodine stain. This is the difference between application of acetic acid, normal pink, abnormal white. In case you have iodine, when you put iodine, normal will stain brown, abnormal will not take up the stain. Okay, right? So this is what happens. So in colposcopy, you look at the different patterns, but the most important thing is that taking a biopsy from areas that appear abnormal. So therefore, I've spoken about all your screening tests, which is the best screening method. Now I will talk about Indian guidelines. Okay, so there are different guidelines. CA cervix is one topic which is hot all over the world. Get it? So your WHO will have separate set of guidelines in one country, and you look at your European counterparts, they will have separate guideline when it comes to screening and so on and so forth. In India, what we currently follow is the FOXI. FOXI is a Federation of Gynecological and Obstetrics and Gynecological Society of India. So this is the guideline that we currently follow, right? So now, while FOXI says that HPV testing is the best method, however, in a low resource setting that doesn't have HPV testing, cytology or co-testing with both HPV and cytology and VIA are all valid options. Okay, now what's very important is that another question they can ask you in your exams, it can just come as a short note: what is co-testing? So these tables are very important. This particular table shows your resource stratification and suggested modalities for screening and management of precancerous lesions of cervix. Good resource setting is like NEIGHRIMS, where you have everything, right? Limited resource settings would probably mean your PHCs, okay? So in your limited resource setting, which is the most ideal, like I said, VIA. Why? You only need your acetic acid, basically. High resource settings, you'll need a cytology lab, meaning you'll need a pathology department, right? And you'll need a lot of other things. You'll need your speculums, you'll need your smears, you need your fixatives, and so on and so forth. So in a good resource setting, you can do any of this. You can do only a primary HPV DNA. Currently, we don't follow that, but in institute like AIMS, that's what they follow. Institutes that are richer, they can follow that. Or co-testing. When I say co-testing, it means both HPV and cytology. What do I mean by cytology? Pap smear. What are the types of pap smear? Conventional or your liquid-based cytology, right? Or it can be just cytology or just VIA. In NEIGHRIMS, what we follow right now is just your cytology. What type of cytology? Liquid-based cytology, right? So this is what we do. So again, this is not really important for you. You can just, depending on whether the institute is presently screened by cytology, if yes, then you continue screening it. If it's a low resource setting, then you switch to VIA, right? So this is a summary. This is very, very important for you. So good resource settings, for example, NEIGHRIMS. Limited resource settings, like I said, a far-flung PHC. So modality, out of all the screening modality, the most preferred, at least in our Indian setting, is your HPV testing. If not HPV, then you can also do co-testing, that is HPV and cytology. If you do not have HPV testing, cytology alone is good enough, right? And then if suppose there are any abnormal changes and you want to have a diagnostic test, mind you, all these modalities that I've been talking about are just screening modality. But if you want a definite diagnosis, you'll do what? A biopsy. That is very, very important. Okay. A limited resource setting, of course, your VIA, very unlikely that you have a colposcope in your PHCs. This is very, very important. When do you start screening women for CA cervix? So ideally, all Indian women, okay, should be screened. In the West, the cutoff is 21 years here. In a good resource setting, 25 to 65 years are the target age group that should have a pap smear. And in limited resource setting, 30 to 65 years. Okay. Now, age to start is at 25 years. Or if you're going to do co-testing, that means both HPV and cytology, that is at 30 years. Limited resource setting, we started at 30 years. Frequency, primary HPV testing or co-testing. Co-testing means your HPV and cytology together. every 5 years. The same is for your limited resource settings, every 5 years. And if it's just cytology alone, then it is every 3 years. Okay, so the reason why we increase the span to 5 years is because when you do HPV testing alone or co-testing, okay, the sensitivity and specificity increases when you combine two tests together. So you can wait up to 5 years. But if you're doing only a pap smear, then ideally it should get done every 3 years. So this particular slide is very, very, very important. Sometimes you can get a question only on this. Okay, what are the different modalities of screening in India? What is the target age group where you start, and what is the frequency of testing? Now, FOXY GCPR means your good clinical practice recommendation. This is what has been recommended in India, right? And the reason why we take a later, why is it that we start, now if a girl is sexually active at 13 years, why do you wait till she's 21 or 25 years? Because like I said, for HPV infection, okay, to actually cause any changes in the cervix, it takes a long time. So it's no point screening the patient as soon as she becomes sexually active, right? Now again, frequency, age to stop. When do you stop screening? So in both, whether regardless of good resource or limited resource setting, 65 with constitutive negative report in the last 15 years, or in the last, if her previous 3 tests have all come out negative, then you can stop the screening at 65 years. Now follow-up after treatment, HPV testing preferred, or cytology after 12 months. This is after treatment, mind you, right? And then after that, okay, so do hysterectomized women need screening? That'll also remain, that will depend on whether the cervix was removed or not. If the hysterectomy was done for only a benign lesion, no need for screening unless there's history of previous CIN, right? Okay, that's it. Right, so understood? Any questions? Yeah? Okay, so in my next class, I'll be talking about CIN. Right, so your CIN is nothing but your cervical intraepithelial neoplasia. I have not added HPV vaccine in today's class. I'll talk about HPV vaccination along with CIN, okay? But today's topic is extremely, extremely important. One, why? Because the incidence of cervical cancer is so high, more likely than not, you will get a patient of CA cervix in your exams, right? So either in your practical exams or your theory exams or your viva, they will definitely ask you something from CA cervix. Okay, thank you.
Thank you, ma'am.